Welcome back. This section is about arrhythmias, but to diagnose an arrhythmia, you need to compare it to a normal ECG. And so, before we can launch into our discussion of arrhythmias, we have to thoroughly understand sinus rhythm. So let's consider that right now. The flash shown in this diagram defines the point of origin of the electrical impulse in this rhythm and in all the remaining diagrams that you're going to see. And this red flash is the location of the sinoatrial node. It has a resting potential of minus 55 to 65 millivolts. Its phase 4 depolarization rate takes it from a baseline value of minus 65 millivolts to the threshold value, which is approximately minus 45 millivolts. Now for sinus rhythm, let's make a distinction between the intrinsic rate of the sinoatrial node depolarizations, which is quite high, but what we actually see in a patient in health is the resting rate, which is the effect of the parasympathetic nervous system slowing down the intrinsic rate from about 110 down to about 72 beats per minute, which is the resting rate. So let's state the obvious. Sinus rhythm is not, of course, an arrhythmia. Here's a typical sinoatrial node action potential. In health, parasympathetic tone is continuously present at rest, and it hyperpolarizes the sinoatrial node action potential such that its baseline is more negative at approximately minus 75 millivolts instead of minus 65. The diastolic membrane potential drifts in a less negative direction at a constant rate of phase 4 depolarization. That is, the gradient of this line remains constant, so the initial hyperpolarization means that a longer interval must pass before the threshold level of minus 45 millivolts is reached. Therefore, with a normal physiological degree of vagal tone, the heart rate must slow down. It takes longer to hit threshold. So normal sinus rhythm has a resting heart rate of about 72 beats per minute. So you must appreciate that this sinus rhythm at 72 beats per minute is due to tonic vagal activity. If the parasympathetic and sympathetic nervous system influences are antagonized with generous doses of atropine and beta blockers together, then the intrinsic or natural rate of the sinoatrial node at 110 beats per minute is seen. Now, let's talk about sinus arrhythmia. So now you are familiar with the effect of vagal tone on heart rate. Now, sinus arrhythmia is sinus rhythm with the now familiar changes in vagal tone superimposed. The degree of vagal tone is cyclical, and this cyclical waxing and waning is related to the function of the respiratory system. These changes in vagal tone occur in response to changes in ventricular filling with the respiratory cycle. In inspiration, the increased negative intrathoracic pressure causes an increase in the volume of the pulmonary vessels. Blood accumulates in these vessels and left ventricular filling decreases. Decreased filling causes decreased stroke volume. This leads to decreased cardiac output and ultimately to decreased blood pressure. This is a negative Frank-Starling sequence. A decrease in blood pressure activates the baroreceptor reflex, which initiates a compensatory increase in heart rate. So you must remember this. There is a compensatory increase in heart rate in inspiration, and heart rate then slows in expiration. The mechanism of sinus arrhythmia is as follows. The baroreceptors inhibit the parasympathetic tone and the electrophysiological effects on phase 4 pacemaker cells of the sinoatrial node, as we discussed earlier. It is the baroreceptors inhibiting a vagal inhibition on the heart, leading to an inspiratory increase in heart rate. Sinus arrhythmia is a normal finding in the young in whom vagal tone is high, so the effect of baroreceptor inhibition is more pronounced in the young. So remember, sinus arrhythmia is completely normal. However, when we see extreme sinus arrhythmias, these may suggest that there is underlying pathology. Now let's talk about sinus tachycardia. Definition of sinus tachycardia is a sinus rhythm at a rate greater than 100 beats per minute. In the majority of cases, sinus tachycardia is an appropriate response secondary to another cause. When trying to identify the cause of any cardiovascular abnormality, we can frequently approach it this way. The cause may be either systemic or local. By this, I mean that the cause is either outside the cardiovascular system, that is systemic, such as pain, anxiety, fever, or a side effect of a drug. Or it can be local, that is within the cardiovascular system, such as a response to a low stroke volume or a low cardiac output and or a low blood pressure. The mechanism of sinus tachycardia is usually triphasic, as we saw earlier, baroreceptors can inhibit parasympathetic innervation of the heart, and they are not the only mechanism which can do so. When exercise requires an increase in heart rate, the initial increase is due to the cardioaccelerator center, which is a component of the cardiovascular center in the brainstem, causing inhibition of the parasympathetic nerves to the sinoatrial node. This parasympathetic withdrawal increases heart rate initially from about 72 beats, the resting level, to 110, the intrinsic level. So inhibition of parasympathetic inhibition allows the appearance of the intrinsic sinoatrial rate. From 110 beats per minute and above, further tachycardia is driven by sympathetic activation of the peripheral sympathetic nervous system, that is the cardioaccelerator nerves arising from the intermediolateral horn at thoracic levels T1 to T4, whose postganglionic fibers directly innervate the sinoatrial node. At even higher levels of exercise, adrenal medullary epinephrine release increases the heart rate further until it reaches a maximum of what is normal for an adult male of 220 minus age for adult males and 210 minus age for adult females. Occasionally, sinus tachycardia may be a manifestation of a primary electrophysiological disorder, for example, tachycardia bradycardia syndrome or sick sinus syndrome. So here is a list of causes of tachycardia unique to the threats we see in the intensive care unit or in the operating room. Now let's discuss sinus bradycardia. The definition of sinus bradycardia is sinus rhythm at a rate of less than 60 beats per minute. In the majority of cases, sinus bradycardia is an appropriate response secondary to another cause. Again, we define the causes as systemic or local, either systemic outside the cardiovascular system, such as pain, anxiety, intense emotional reactions. All these can cause bradycardia. A vasovagal response is a good example, or bradycardia can be due to a beta blocker or a calcium channel blocker. The cause may be within the cardiovascular system, such as a baroreceptor response to severe systemic hypertension, or even a response to intracranial hypertension. As already emphasized, the mechanism of sinus bradycardia is often parasympathetic activation-induced hyperpolarization of the sinoatrial node resting potential. Occasionally, sinus bradycardia is, of course, a manifestation of a primary electrophysiological disorder. Again, tachycardia, bradycardia syndrome may be the cause. There are causes of bradycardia other than sinus bradycardia, and these will be considered in the appropriate section. Here's a list of causes of bradycardia, again, pretty much unique to the threats that we find in the ICU and the operating room. Shortly, we will consider the clinically common arrhythmias, but we will pay special attention to the life-threatening arrhythmias in the context of their recommended ACLS treatment algorithms. ACLS is Advanced Cardiac Life Support, and the ACLS arrhythmias are ventricular tachycardia, including torsade de pointes, ventricular fibrillation, asystole, and something we call pulseless electrical activity, or PEA. Let's deal with asystole and PEA now, because neither of these are true arrhythmias, and we can dispense with them quickly, but let's not minimize them. They're massively important in clinical medicine. Initial resuscitation of asystole and PEA follows the same algorithm. Now, PEA, pulseless electrical activity, refers to a heart rhythm or an arrhythmia that typically can generate a pulse. That is, they are output rhythms. We need to make a distinction here. An output rhythm as opposed to an arrest rhythm. But in PEA, the rhythm is not generating a pulse. The rhythm should be able to generate a pulse, but it is not. Most episodes of PEA occur with sinus tachycardia, so there's no arrhythmia to treat. We don't treat PEA with antiarrhythmic drugs. This rhythm is usually perfectly capable of generating an output, so it is an output rhythm. But in PEA, the ventricle cannot mechanically generate a stroke volume, either because the ventricle is empty due to obstruction of blood flow into the ventricle, such as occurs in tension pneumothorax or tight pericardial effusion or pulmonary embolus. So this is termed obstructive shock. Or the problem could be a biochemical or electrolyte abnormality which interferes with the ability of the cardiac myocytes to contract, and we call this electromechanical dissociation. And this was the old name for PEA, electromechanical dissociation. Now, moving on, asystole is similar. There's no arrhythmia to treat. There is the total absence of cardiac electricity, and there's no cardiac mechanical activity because there's no electrical depolarization. So again, there is no arrhythmia to treat, but this is a terribly lethal condition, and we have to act aggressively and quickly to get the patient out of asystole. The treatment rationale for asystole is to keep the patient alive until you can get them into ventricular fibrillation. If you can get them into ventricular fibrillation, then you have an arrhythmia which you can shock. First priority is keeping them alive with really incredibly high quality chest compressions. In asystole, there is no fibrillation, so defibrillation has no place here. Never shock asystole. Our second priority is to use very high quality chest compressions to generate the best myocardial blood flow and cerebral blood flow that you can get. And if we can get enough blood flow to the myocardium, we may get the patient into ventricular fibrillation. They may spontaneously revert from asystole to ventricular fibrillation, and we can do this with epinephrine intravenously. And then the third priority is to treat VF as per its algorithm and to shock it ASAP. Now, of course, all this will make much more sense once you are immersed in the subsequent arrhythmia presentations and once you've read the ACLS manual. But for the moment, this is enough information so you have the fundamentals for when it comes to studying ACLS. This is resuscitation medicine, and it is a very, very exciting and rapidly changing area of medical practice. We will continue this very exciting discussion on the management of serious arrhythmias in the next video. Thank you for watching.